Now look at the ECG changes in acute coronary syndrome, beginning with unstable angina. The ECG, also known as the electrocardiogram, is very important to diagnose acute coronary syndrome, specifically STEMIs or non-STEMIs. However, 20% of ECGs may be normal initially. ECG shows 5 main waves, which correlate with parts of the heart while it's contracting and relaxing. These are the P wave, QRS complex, and the T wave. In unstable angina, you don't usually see any ECG changes. It is usually normal, or you can see a T wave inversion, so a dipping of the T wave. To understand the pathophysiology of unstable angina, as well as the other acute coronary syndromes, let us just recap the coronary arteries and the heart, the ventricles here. So you have the right and left coronary arteries, which are the first 2 branches of the aorta. The left coronary artery divides and forms 2 other big arteries. The left anterior descending, which supplies the anterior and septal parts of the heart, and then the left circumflex artery, which supplies the lateral wall of the heart. Myocardial infarction or heart attack tends to occur within the left anterior descending, and then the right coronary artery, and then the left circumflex. If we take a cross section of the heart like this is what it would look like. And here is where the right ventricle is and your left ventricle. This in front here is the left anterior descending, which again supplies your anterior wall of the heart as well as your septum in the middle. This is your left circumflex artery, which supplies the lateral wall of your heart. And at the back, wrapping around, is your right coronary artery, supplying the right wall and posterior wall of the heart. But now we will mainly focus on the left ventricle. Of course, you have the other layer of the heart called the pericardium, which essentially is a sheath that wraps around the heart and actually wraps around the coronary arteries as well. Let's take a closer look now at the left anterior descending artery and what happens in unstable angina, which make up one of the 3 types of acute coronary syndrome. So here is the cavity of the left ventricle. The 3 layers of the heart from the inside is the endocardium, myocardium, and the epicardium. Epicardium also make up part of the pericardium as well. Again, here we are focusing on the left anterior descending artery, which is the most common artery affected in heart attacks. Now, in unstable angina, you get reduction in blood supply to the heart muscle as a result of the plaque, and which is partially occluding the artery. And so you get ischemia to the muscle wall, but you don't get infarction. And this can occur at rest and can cause symptoms of angina, the chest pain. However, unstable angina can progress to a non-STEMI. In a non-STEMI, you get significant occlusion of the artery because of a ruptured plaque, subsequent thrombosis, leading to poor oxygen supply. But the artery is not fully occluded. The significant reduction in oxygen supply to the muscle wall causes infarction distally and ischemia proximally to the artery supply. The infarcted area is called a subendocardial infarction. Interestingly, the endocardium is not infarcted because it is receiving blood straight from the ventricle, the cavity where the blood pools essentially. Subendocardial infarction is a characteristic of non-STEMIs. Non-STEMI is called non-STEMI because on ECG you do not see a ST segment elevation. Rather, you see an ST segment depression, and this is the characteristic finding of a non-STEMI. A non-STEMI can progress yet further or can result from a transient STEMI. A STEMI again is characterized by a ST segment elevation on the ECG. What happens in a STEMI is you have a complete occlusion of the artery essentially because of the ruptured plaque, subsequent thrombosis, causing complete occlusion. Complete occlusion means you have no blood supply to the myocardium, and this means you have initially infarction distally to where the vessel supplies, and the infarction will progress proximally very rapidly until you get a transmural infarction. Transmural means essentially trans, which is across, mural, so across the whole myocardium essentially. With a transmural infarction, you can also cause damage and rupture of the papillary muscles here, which help the heart valvular function. Damage to the papillary muscles results in other complications such as mitral regurgitation or mitral prolapse. With a transmural infarction, it is very important to also look for ECG findings which suggest a new left bundle branch block. To find a left bundle branch block, just remember the name William. The L in William suggests a left sort of bundle branch. The W and M of William tells you what features to look at leads V1 and lead V6 on the ECG. In leads V1, you see a widened QRS with a W shape or pointing down. And V6, you see a widened QRS in an M shape or the QRS pointing up. A new left bundle branch block may suggest infarction of the septum of the heart, where the left bundle branch goes through. Remember, the septum is also supplied partially by the left anterior descending artery. Finally, let's talk about the cardiac markers. In a STEMI, you see elevation of cardiac markers. Similarly, in a non-STEMI, you also see elevation of cardiac markers such as troponin. But in an unstable angina, you got none. You got no cardiac markers. So let's just say you're at the emergency department and someone has presented with the signs and symptoms and the risk factors suggesting acute coronary syndrome, specifically a STEMI or a non-STEMI, a heart attack essentially. And you've performed the investigations and diagnosed a STEMI or non-STEMI. And you've done this because you looked at the troponins and the ECG findings. Now, the management of acute coronary syndrome may differ depending on what country you're in, but essentially, it's easily remembered as moan, such as moaning. And this is performed on all suspected cases of acute coronary syndrome. And this includes M for morphine, or specifically for opioids, intravenously. O is for oxygen, if the oxygen is low. A is for aspirin, as well as clopidogrel, to protect the heart from further insult, as well as nitrates, to reduce the workload on the heart and to allow for more oxygen flow to the heart. So the initial management was moan, but what's next? So after the initial management, it is the definitive management. So in a STEMI, the ST segment elevated myocardial infarction, emergency reperfusion is commenced. The first choice or first line is primary percutaneous coronary